A new medical school is being proposed for the University of Nevada, this one in Las Vegas. Why do we need another medical school? How would it be paid for? And would it help or hurt Northern Nevada? This is a conversation about Nevada's second medical school. After decades of talk about a Southern Nevada medical school, deals have been struck. And the man who's probably most responsible for getting the ball rolling is the man who's in charge of the University of Nevada School of Medicine, Dr. Thomas Schwenk. Dean Schwenk, thank you very much for being here today.
It's a pleasure to be here.
First of all, tell us why we need a second medical school and why now, when the state is still rebounding from a bad economic time.
Well, there's no question that it's not the greatest economic time to do this. The conversation actually is bigger than a second medical school and really deals with public medical education throughout the state, both Reno and Las Vegas, as well as the rural communities, and growing the entire enterprise. A second medical school is part of that, but that's not the primary goal. The primary goal is just to expand across the state. It will lead inevitably and desirably, I think, to a school at UNLV. But I really want people to focus on the larger issue, which is growing the entire enterprise, both medical students as well as residents and fellows.
A lot of us who know that we have a medical school don't really know what we have. What do we have currently in Reno and what currently exists in Las Vegas?
What we have really is a 2+2 school. Meaning 2 years in Reno, preclinical teaching, basic science teaching, outstanding basic science research, outstanding scientists who collaborate with physicians to teach the basic sciences, and some clinical skill teaching. And then 2 years in Las Vegas of clinical training, the third and fourth years. So all students have to go to Las Vegas for some of their clinical training. Some students stay in Las Vegas for all of their clinical training. Some come back to Reno for some of that. But the problem is, when you have two campuses 448 miles away, which I think is the correct distance, it's very hard to manage that. And it's hard on students. We know that students in the north are probably somewhat more inclined to come to the University of Nevada because they're oriented to Reno, oriented to UNR. They understand that they're going to Las Vegas for a lot of their clinical training. We worry that we're losing some pipeline of Las Vegas students who might not be inclined to go to Reno for 2 years, come back to Las Vegas for 2 years, then maybe have to leave the state for residency training, which is the other huge piece, and maybe the dominant piece is the resident and fellowship training that we have to expand.
So many different directions we want to go from that topic of conversation. But first, what is the proposal? What deal has been struck?
So the fundamental agreement, the memorandum that's been signed, speaks to the issue of expanding medical education across the state. The fundamental purpose is to grow up a full campus in Reno, meaning build on the preclinical teaching, add a whole layer of clinical teaching with all the clinical clerkships, all the specialties in the third year and electives in the fourth year, so that there's a full campus in Reno and a student could reasonably expect to spend the entire 4 years in Reno. And then expand residency training in Reno so that they might even stay on, especially in primary care disciplines like family medicine or internal medicine, possibly pediatrics, psychiatry. Build up that campus and then do the same in Las Vegas. But it's the opposite issue. So in Las Vegas, we have great clinical teaching, but we don't have the basic science research. We don't have the preclinical teaching. We don't even have an auditorium in which we can hold all of our students and residents. So we need teaching facilities, classrooms, research labs, cadaver lab for teaching anatomy, animal facility perhaps for basic science research. We have to grow all of that up in Las Vegas. So we have sort of diagonally opposed objectives. Clinical training in Reno, basic science teaching in Las Vegas. Grow up both of those campuses. That is really the fundamental purpose of the agreement. But we all recognize, we all are in support of moving as expeditiously as funding will allow towards UNLV taking over the operation and becoming a full school in Las Vegas.
When you say we need more everywhere, some of us have heard statistics that we rank 50th in the nation in the number of doctors per capita. looking at it from inside the profession, how severe is the problem?
It's severe. I don't think we're quite 50th. We might be 46th or 47th, but it's bad. In more absolute terms, we might have half of the doctors per capita or 2/3 of the doctors per capita as the higher ranked states might have. I mean, that's a pretty dramatic difference. We are very short in primary care, as is most of the country, but it's probably worse in Nevada in certain regards. But unfortunately, we're short in many specialties. So I could list a whole range of specialties, some of which are more plentiful in other areas of the country, but not here. So we are way behind. We're also behind in residents per capita. So in terms of the training programs, that's reflected then in physicians per capita, because our training programs are not as robust as they should be. So we are in trouble, and especially in terms of healthcare reform and Medicaid expansion, which the governor has supported. That's going to bring 200,000, 300,000 new people into the system in Nevada. It's not clear where the capacity comes from to bring those people into a good primary care system.
That's one of the things that we discussed earlier on the phone, is that when we dealt with what we are referring to as Obamacare now, and with the expansion of Medicare, we've dealt with one of the big social issues, which is getting people into the system, but we haven't built the system to support them, and that's a nationwide problem.
Yeah, that's a huge problem. Politically, I think the president wanted to start to look at how health care is actually delivered, and for a lot of reasons they just couldn't touch that. There was too much political opposition, so they really focused on access. Get people into the system, provide access, provide insurance, provide subsidies, and that seems to be making some progress. The bigger issue, though, is how healthcare is actually delivered, and that's the next step. How do we actually organize physicians? How do we organize teams of health professionals? How do we develop partnerships between physicians and hospitals, for example, so that we use this expensive technology very carefully, very parsimoniously? How do we measure quality? How do we measure value? I mean, the reality is the Institute of Medicine, as many people know, released a report a year ago, 2 years ago, that supported what everybody believed, which is about 30% of everything we spend on health care is either wasted or unnecessary or dangerous or goes to unnecessary administrative costs. 30%, $750 billion a year, is not contributing to our health. The question is, which piece of health care is that, and how do we kind of wring that out of the system? That's a whole other question.
I hope to come back to that, because I know this is a passion of yours and you have many ideas about it. But back to the medical school in Nevada, you talked about residency. I believe studies have shown that roughly 2/3 of doctors who perform a residency in a given community are inclined to stay in that community. Right. So that seems a ready-made fix to some degree, and I know that the medical school is working with Renown on a partnership to develop more of that. How much can we assure that doctors who train here stay here?
Well, you never can be certain. That the students have many choices, and they can go to many places. We are proud of the fact that our medical school graduates rank very well and perform very well and are very highly desired. So we have students who seek and gain residency training in outstanding places around the country. There's no direct connection between the medical student pipeline and the resident pipeline. It's a complete disconnect. So once you finish school, you can then sort of start fresh and look at where you want to go and look at other parts of the country. So we have to be very competitive, and that's a key issue. It's not just an issue of availability of residency training, it's an issue of quality. And we have to have the most outstanding programs, be able to recruit the best faculty members, have the best access to the best populations of patients, so that residents can learn under the supervision of outstanding physicians. Residency training in particular, medical education in general, is very expensive, and I understand that, and I know that people have concerns about that. But then, of course, we're training the next generation of physicians who will be taking care of all of us. I think that's worth some investment, but I understand that it's expensive.
How about recruiting students too? There seems to be the assumption that if you build it, they will come.
Right.
Is there really a guarantee of that?
We have outstanding applicants, and there's no question that there are qualified applicants who we have to turn away. So I think there is a pipeline, but I'd like to actually draw some larger circles around the state, start to attract students, for example, whose parents are alumni, or students who have Nevada connections who might be more inclined to come back and stay in Nevada, or start to attract students from surrounding states, or maybe tap into some of the California counties that border on Nevada, so students might want to come across the border. So we have to, I think, be selective, be careful, be strategic in how we develop pipelines of students, and this is particularly true in Las Vegas. We think that there is a pipeline of students now, some of the top students in Las Vegas who leave the area, they go away for undergraduate education, and they just don't come back. And we need to be able to bring them back and to show them really outstanding education in Las Vegas and opportunities to stay in Las Vegas to train. So you're right, it takes a lot of work to develop those pipelines. We work back into high schools, back into middle schools. We want to develop pipelines for students who might not otherwise have thought about going to medical school, and bring them along and give them a route through undergraduate education. We have a great program that combines a bachelor's degree with a medical degree, so you can come into either UNLV or UNR and link that with the medical school. We want to expand that pipeline. So it's a lot of work, no question. If we're going to expand, we really have to work hard to develop the supply into the system.
Well, not only are you talking hard work, but an awful lot of money. And we've already mentioned that this doesn't seem like the best time. How much money will it take to build out both the northern and the southern medical schools?
I think the first step is to begin to develop the campuses, and we think we can probably do that for $20 million a year, maybe $25 million a year, to expand out the campus in the north, expand out the campus in the south, start new medical students in the south, and begin to have a more robust enterprise. That compares to the $30 million a year that the state appropriates to the school now. But you have to understand that that $30 million is only about 19% of our total budget. So the total budget of the school is about $160 million, of which the state provides 30. So if we're going to expand a second campus in Las Vegas and eventually a UNLV School of Medicine, there have to be other sources of revenue: clinical practice revenue, physician faculty members who practice and generate clinical revenue, contracts with hospitals, research grants, philanthropy. So it's a very robust enterprise that goes way beyond state appropriations. But back to your question. So expand the campuses might be 20 or 25 million. Eventually, when there's a second school, we're talking about another 30, 35, maybe 40 million. There are schools around the country right now. In Texas, for example, a new school at the University of Texas in Austin, and they're budgeting somewhere around 65 million a year. I don't think we need that much, although I'd be happy to receive it. But I think that we need to recognize that if we're going to really expand the workforce in Nevada, it will be an expense. But again, we're talking about the future of healthcare in the state, and whether Nevada really stays on the right side of history in terms of providing outstanding care and developing systems of care that will keep people in the state and provide access and provide specialties that do not now exist in the state.
We also have studies that help back you up. The Tripp-Umbach study suggested an economic benefit to the state of about $500 million a year. Yep. That's at the low end, and following one of the models, up to almost $2 billion a year. So I see a lot of benefit that the state could get by investing state money toward those schools. But if I'm a businessman, I want to know, what's the return on my investment? How long will it take?
I think it'll take several years. If we started tomorrow building the campus, then building residencies, it would be 6 years, 8 years, 10 years for some specialties before you would see new physicians coming out. And I understand that that's a long time, and that may be somewhat discouraging to politicians or to the public who aren't sure that they want to invest for a long period of time before they see a return. My response would be, that just means we have to start now. That we're behind. I get the fact that we're behind. We've not been able to invest for many, many years. The school's been small. There have not been very many hospital partners with whom we can develop residency programs. So yeah, we're behind, but that just means we need to get to get going. And again, there's so many benefits to this. The Tripp-Umbach study does show direct economic benefit, but there's a lot of non-economic benefit here too, in terms of quality of life, the perceived quality of care, businesses who would move to the state because they perceive that there's a high quality of education, high quality of care here. In Las Vegas in particular, we know, and many studies have shown, there's a huge outmigration of patients who go elsewhere, particularly Southern California, but other major centers, for their care. That doesn't speak well. And it's particularly unfortunate because there are really outstanding physicians in Las Vegas. There are outstanding medical groups. For some reason, there's a perception that patients want to bypass that care and go elsewhere. And I think what the school does is to sort of bring that expertise together. It becomes sort of an organizing force, kind of a defining force for quality. And people say, look, we have a medical school. I see these physicians who are on the faculty. I see these students in residence. I know where to go to get quality care. And that's what we have to really build.
You become a bigger part of the community.
Absolutely.
And from the community perspective, let me ask something very selfish here. If I'm in Northern Nevada, and there's a huge expansion in the medical school, do I benefit from that, or am I sending a lot of my money to Las Vegas?
I think that everybody benefits when the quality goes up and when the enterprise expands. I understand that there's a lot of political tension that goes back years and years and years.
Rivalry, you could say.
Yes, or more. And I've been subject to some of that, shall we say,
you have to
over the
work
years.
at both ends.
That's right. So I get that. I think that everybody should feel like their investment has value to them, that investing in each community, and always remember the third campus, what we call our third campus, which is rural communities. They should feel like they have a stake in this as well. So we're developing programs, for example, to train physicians in rural communities. Great news recently, we just were approved for a program to train family physicians in Winnemucca. And now that's a very exciting program. So I understand that everybody's touchy about where their tax money goes and whether there's a return and is there money going from north to south or south to north. I get all that. I think that everybody benefits when this enterprise expands, and everybody can see that direct benefit. Let's
talk a little bit more about what you see as the future of healthcare. A lot of us are concerned about the direction in which things are going. It could be a concern over socialized medicine. It could be a concern over that waste of money. It could be that I'm not sure my doctor is still going to be around in 5 years. We're seeing private practices go away. What trends do you see, and what do you think we need to be doing?
I think the fundamental issue is that we have to have a different definition, a different concept of quality and value. We're still practicing in a post-World War II model, which is do things. We have new technologies, let's do things to people. Doing things must be good. There's sort of an intrinsic value to prescribing new drugs and ordering new tests and performing new procedures. And we really have not given that a real hard look as to what truly has value, what truly has been shown to work. So we're really good at developing stuff. We're really good at ordering stuff. Doctors are really good at ordering things. When a patient comes in the office, I can order a phenomenal amount of expensive testing in a really short period of time. The question is, how do I know that there's value? How do I know that I'm improving the patient's life? How do I know that there's a known quality to what I'm going to do?
Especially when you could be creating hardship, financial hardship.
Absolutely. And we need to have a system in which patients will ask some of those questions. Patients will push a bit and say, look, doctor, I read about this. I know there's some controversy. It might work, might not. How do I know that this is right for me? So I think that we as a profession have an obligation to begin to answer some of those questions. The problem is that research is extraordinarily difficult, extraordinarily expensive. It's a lot easier to develop stuff than it is to really assess its long-term value, and we have to start organizing the system to provide that quality. Right now, we get paid for doing things. We get paid by volume. And so the main conversation in healthcare reform is switching from volume to value, and not just doing stuff. Even if we do it right, that's good, but instead of just doing something, let's think about what the best way is to provide value to that. that
Quality
patient.
versus quantity.
Yeah, exactly.
Now, you already do that to a large extent in the classroom. How do you instill in the next generation of students that that's a mindset?
Well, I'm somewhat chagrined to say that I don't think we do a great job at teaching about this. We try, and we try to expose students to this, but the forces in the system are so strong in terms of how physicians are paid, how health insurance is constructed, how payments are made, how reimbursement is developed. It's really hard to fight some of those forces. I think what's happening behind the scenes that's really important is that employers and the government, who are the prime payers for health care, are starting to understand that they have to take the lead here. And so employers are saying, look, if studies say that a third of what I spend for my employees on health care is not of value or is wasted or even dangerous, I want to start taking a look at that. I want to start looking at how to provide better value, how to get better value for my health care dollar.
That scares me as a consumer, because then something that my doctor orders is going to be rejected by the insurance company.
Then the R word, rationing,
Yes.
comes up, and there's no question about that. We somehow have to help people understand that just doing things is not intrinsically good. It might be good, but it might not. And I would say that in my long career as a physician, I've practiced as a family physician now for 35 years. My experience is that if you can really spend the time to talk with patients, explain the pros and cons, talk about different options, talk about different approaches, really understand their values, what's important to them, what are they trying to achieve with their health care, that rationing never comes into this. You can always do the right thing if you understand what the right thing is, but it takes time, and there should be reimbursement for that. There should be support for that. I mean, that's what patients want. They're always
We
upset.
want communication, but you're not
Exactly.
paid for
but
communication.
We're not paid for it. We're paid to do stuff.
That's right.
Yeah. So if I could spend more time, if I could really spend the time to explain to patients, and I do whenever I can, the results are almost always positive. Patients get really upset when the system just kind of takes over and just starts doing stuff, and it may not come to the outcome that they desired, and then they kind of wonder, well, how could we have maybe had a little conversation about that, ahead of time, and sort of sorted out a better approach.
It still comes down to the human being. Let's talk about you as a human being. We've been hearing from Dane Schwenk, which is a title that you've had for 2.5 years now. Who is Dr. Schwenk? Who's Tom Schwenk?
So I'm very proud to say I'm a family physician. I went to the University of Michigan, first in chemical engineering, and then decided after that to switch into medicine. And the longer I was in medicine, the more interesting people became. So I went into family medicine, trained at the University of Utah. I practiced in Park City, actually. I was the first doctor of the modern era in Park City. Was there for several years, built up a practice, brought in partners, then went back to the University of Michigan, where I had my more academic career. But I've always practiced quite aggressively throughout that time. And I still try to stay connected. I try to volunteer in free clinics here and in Las Vegas. I teach family medicine residents here and in Las Vegas, not as much as I used to. But I think I still have the connection to patients and to students and to residents and to what's happening in healthcare. And so as to connect that to these larger responsibilities in trying to contribute to this conversation about growing healthcare.
And that's something that fascinates me, because a lot of us, when we are obviously at the brink of change, we may say, this is enough, I want to get off here. You see that we are on the verge of tremendous change, but you want to be part of that, and it excites you.
Oh,
you have hope for the future.
I do, and I guess it's because I think there's an enduring value to the physician-patient relationship, to the quality of the human relationship in medical care, that there's a fundamental nature to that relationship. And certainly with patients and other healthcare professionals, it's not just an issue of physicians. This really affects all healthcare professionals who are going to come together as a team. And I think that relationship is so powerful that it will ultimately win out in terms of how the system responds. And I also think people are understanding that healthcare, access to healthcare, quality healthcare, could be seen as a moral issue, but it's also an economic issue. I mean, this is really an issue that has to be solved if we're going to be competitive in the global marketplace, if we're going to develop other sectors of the economy. We have to understand how to provide high quality health care that really meets people's needs, also has great outcomes, also is cost effective. So it's a very powerful event that's taking place. But I think there's such intrinsic good to what goes on here that it will figure itself out.
In 30 seconds, can you give us advice as consumers? What do we need to be demanding of our doctors, of our lawmakers, as we go through this period of change?
I think that patients should be working very hard to find a physician with whom they can develop a really strong relationship, an office staff, other health professionals who really respond to their needs, and then convert that to the larger system, which is, if I can have this relationship, if I can have this quality of care, then I think the state should work to be able to provide that for everyone. We should train doctors in that fashion. We should develop systems that support that. So take your personal experience, make it as good as you can, ask questions, develop the relationship, and then convert that to the larger system.
I like that. It's community-based. Dr. Thomas Schwenk, a family physician, the dean of our University of Nevada School of Medicine, and he says that we're in for a lot of change in the health system, and I think he's going to be at the forefront of that change. Dean Schwenk, you have opened our eyes a great deal. Thank you very much for being here.
I enjoyed the conversation.
Well, I appreciate your insight. We're going to be watching for progress at both the state level and as far as the industry goes. Thank you for being with us.
Thank you.
And thank you for being part of A Conversation.